Preventing iatrogenic chronic low back pain and disability. Thank you for joining me, as prevention is better than cure. Iatrogenic refers to an illness inadvertently caused by examination, treatment, or a comment provided by a healthcare provider. Yet one of the basic principles of medical intervention, as stated by Hippocrates, is first, do no harm. Let's talk about DDD. Degenerative disc disease, or DDD, occurs over time when the discs within each vertebrae begin to disintegrate. In this presentation, I fully acknowledge the existence of severe disc degeneration and severe spinal stenosis, where a diagnosis is essential for appropriate medical management. However, you have DDD is too often willy-nilly told to vulnerable patients who report of low back pain. All that is needed to give that awful diagnosis is pain, stiffness, and some mostly coincidental radiological findings of joint degeneration in their spine. All healthcare providers and primary care physicians need to realize that by giving the DDD diagnosis to a patient, they have potentially doomed them to a lifetime of pain and disability. In other words, they may have unintentionally caused iatrogenic chronic pain. Let's explain BARF and vomit. All healthcare providers must discontinue the act of BARF, which is the bad application of radiological findings. Let's say a patient is complaining about their persistent low back pain and stiffness. They are then referred to receive an X-ray. When the X-ray report shows signs of degenerative changes, the patient is confidently told in a gloomy voice, "Your X-ray results has come back and shows that you have arthritis in your spine, which explains your back pain." The diagnosis of degenerative disc disease brings with it thoughts of getting old, being fragile, and having to live with permanent pain and progressive disability. You don't believe me? Just Google back degeneration, arthritis, and see the images that come up, scaring the daylights out of people. Seriously, how can any healthcare provider be in any way confident that a patient's back pain is truly related to the degenerative findings seen on an image? That is BARF in action, meaning the bad application of radiological findings. If all degenerative changes in the back resulted in pain, then 90% of us would have low back pain that would persist for the rest of our lives. Those with sciatica also often receive MRIs and are frequently informed of the horrific findings, such as disc bulges, found in their spine, presumably explaining their low back pain and sciatica. This inevitably results in greater fear avoidance beliefs, catastrophization, stress and anxiety, which have all been strongly associated with the development of chronic pain. If all disc bulges in the back resulted in pain, then 3/4 of us would have lower back pain for the rest of our lives. And that's simply not true. What is true is that when people are told of DDD and disc bulges in their spine, they may have a greater likelihood of becoming inactive, a greater number of visits to various healthcare providers to fix their damaged low back, greater use of pain medications, and a greater likelihood of receiving injection blocks. This is the lumbar spine section from the Victim of Medical Imaging Technology or vomit poster. Studies have shown that lumbar disc degeneration is present in 40% of individuals under the age of 30 and is present in over 90% of those between the ages of 50 and 55. And other studies showed that amongst healthy young adults aged 20 to 22 years with no back pain, 48% had at least one degenerated disc and 25% had a bulging disc. Leading physicians at the Department of Neurosurgery at the University of California strongly recommend against the routine use of MRI for low back pain, since they have found no link between degenerative changes seen on X-rays or MRIs and low back pain. Translation: do not panic if your X-ray or MRI shows problems with your discs. They're simply normal changes that happen from the age of 20 onwards. Honey, can you help me move these few boxes? No way. My doctor has told me that I got degenerative disc disease at my L5S1 and 3 disc bulges, and gotta be careful. Patients must be made aware that degenerative and disc changes are not a life sentence to experience pain. The truth is that low back pain is complex and almost always multifactorial, meaning it's not just one thing that is responsible for the pain experience. Patients must also be informed that lifting, carrying, walking, or even running do not speed up degeneration, but may in fact slow it down. Patients must also be educated that despite the presence of degenerative changes or disc bulges in their spine, they must remain active and move as much as possible. Sometimes, recommendations from a physical therapist is required for guidance on the intensity and the progression of the movements and activities. If you're thirsty, you need to drink. If you're hungry, you need to eat. If you're in pain, you need to move. Request your free poster on APTEI.ca clinical shop. Patients must be made aware that avoiding physical activities due to fear of worsening condition can result in further loss of flexibility and strength, which can lead to greater pain experience. The best treatment strategy for anyone diagnosed with DDD is gradual and daily exposure to non-threatening movements and activities. The worst treatment strategy for anyone diagnosed with DDD is rest and permanent avoidance of physical activities that they once enjoyed. A study compared the spine MRIs of runners and non-runners and found that running had a positive effect on disc height and health, meaning those who frequently loaded their spine had less age-related degeneration. Basically, the bad application of radiological findings, or BARF, results in patients becoming a victim of medical imaging technology, or VOMIT. We can reduce iatrogenic chronic low back pain by eliminating the BARF. Because of the high prevalence of a variety of imaging findings in patients without back pain, imaging may lead to a cascade of needless interventions that can be both harmful and expensive. My ultimate wish is for a medical regulation to be passed that all imaging reports must include epidemiologic information regarding findings in asymptomatic individuals. Simple 1 or 2 sentences to inform and assure physicians and patients of the age-appropriate prevalence data. Why not? After all, normative ranges are always clearly stated in blood work lab results. These studies published in the Journal Radiology and the Journal of American Medical Association concluded that patients are less likely to receive narcotics prescriptions from their MDs when normal epidemiologic information was included in their lumbar spine MRI reports. The simple statements added at the end of the imaging reports were, "The following findings are so common in people without low back pain that while we report their presence, they must be interpreted with caution and in the context of the clinical situation." The findings, or the prevalence in patients without low back pain of disc degeneration, which includes disc loss or bulge, is 91%. Signal loss is 83%. Disc height loss is 56%. Disc bulge 64%. Disc protrusion is 32%. Annular tears is 38%. Lumbar spine imaging frequently reveals findings that may seem alarming but are likely unrelated to pain. But sadly, just adding statements at the end of an imaging report is not enough. What truly matters is how the imaging results are communicated with the patient. For the vast majority of times, healthcare providers can replace the term degenerative disc disease with healthy age-related changes. For instance, do not tell patients this: "Your x-ray results came back and it shows that you have degenerative disc disease, which explains your lower back pain. You need to take it easy from now on to prevent further degeneration. You just have to live with this." But tell patients this: your x-ray results came back and it shows that you have some healthy age-related changes. And the good news is that the vast majority of these changes are not associated with pain. You need to stay active and gradually put more load on your spine to make your back more resilient. A good physical therapist can help you with that. This is my 94-year-old grandma. I've been her personal physiotherapist for the past 30 years, where she has complained of lower back pain to me twice, and each episode lasting only a few weeks. There's no doubt that she has severe degenerative changes and several disc bulges in her spine, yet no pain or discomfort. She still walks and uses the stairs independently and can even touch her toes. How do you explain that? I will personally mail you a free copy of the Victim of Medical Imaging Technology, or better known as the vomit poster. You may request one on APTEI.ca, clinical shop. You can also freely access the high-resolution image file of the vomit poster and print it out yourself. You may access it on APTEI.ca under Pain Education. I would be extremely grateful if you shared this video with as many healthcare providers as possible, such as MDs, including family physicians and orthopedic surgeons, PTs, chiropractors, osteopaths, and RMTs. It's up to all of us to spread this message and help end iatrogenic chronic pain and disability. If you have any questions on this topic or need references or would like me to present this information live to your clinic or hospital staff, please contact me. Thank you. This is part of my video series called Preventing Iatrogenic Chronic Pain, available in the video library on APTEI.ca. I really look forward to telling you more about my grandma and her role in preventing iatrogenic chronic pain.